Okay. Did you guys all get the BB Learn announcement about the double quizzes? Okay, sweet. You know, I stopped holding your hand, but because it was a little different, I thought I should send out a reminder. Now you have 2 post quizzes on Friday. Okay. What has 4 wheels and flies? 4 wheels and flies. A garbage truck. Of course. 4 wheels and flies. Okay. All right. You guys are a little slow now. You're still not getting it. Ask your neighbor to explain it to you. Why was 6 afraid of 7? 7, 8, 9. I think that was actually a Highlights magazine one, because that sounds like something I've heard a million times. Because 7, 8, 9. All right. So, we've got a lot of interesting things to cover today. We have not that many slides. We have a lot of material on these slides. And more importantly, how many of you took 201 in the last year? The last year. Okay, like 3 of you. Great. Fantastic. How many of you took it here? Okay, that's great. Not that this is the only place to take it, it's quality, but it dovetails pretty nicely. So what we're going to do is I'm going to encourage you to go to my 201 YouTube shelf that's on our YouTube hosting site. So if you've been watching the lectures, you go to the pathology folder. There's a 201 folder, and you can get into nerve physiology. And I would review some of the nerve physiology material from 201. The other thing that you'll find in the BB Learn shell is you'll see my central nervous system lectures, PowerPoints, in the BB Learn resource folder of pathology. So you go back and kind of review some of these concepts from 201, because we really need to have a solid foundation in the nervous system before we start talking real aggressively about nervous system disorders. And so part of what we're going to do right now is cover, not in an exhausting manner, but in a overview, and mostly to stimulate your mind, okay, what is it that I actually forgot? And what is it that you should probably look back at? Yes, this is all testable material for exam 2, but more importantly, it's critically important before we just start talking about disease states and where things go awry. So in the nervous system, we have 2 main cell types that are shown on the slide here. We have the excitable cell, known as the neuron, and we have the support cells, which are called glial cells. Is that familiar with terminology? If we look more specifically at the central nervous system versus the peripheral nervous system, we see in the central nervous system that the glial cells exist in 4 different flavors. And we see that there's only 2 different flavors in the peripheral nervous system. The oligodendrocyte in the CNS, what is it responsible for? Shout it out if you remember. Making myelin. Someone's doing this, right? Making myelin. Wrapping the neuron. The axon, actually. So the oligodendrocyte is the myelin-producing cell in the central nervous system. And what does that myelin do? Let's review. It insulates. It insulates the axon. And so insulating, what function does it provide? Increases nerve signal transduction, and it conserves the fidelity of the signal, right? So the signal doesn't dissipate out, you don't lose it. Astrocytes. What do the astrocytes do? The astrocytes are what? Anybody? I thought I heard someone say something. What's that? They help with nutrition. So they connect from the blood capillaries to the neuron itself allow for transmission of the nutritional flow to the neuron. And they also provide a support architecture. I thought I heard the word support, but somebody was maybe too shy or not super confident. But wherever you are, you should pat yourself on the back. Right? They kind of brace the neuron and hold it in place. So they provide a support architecture. As I see grins, so I think I know where it came from back there. And they also provide nutritional supply to the neuron. Okay, and you know that neurons need blood flow because if they are starved of blood flow, right, like if you sit on your leg for too long, you're cutting blood flow off to the distal extremities, and those peripheral nerves start to, we say, fall asleep, or they're actually starving from oxygen depletion. And that pinprick feeling that you have, that parathesis is what that's called, that numbing and tingling, that's the first sign of nerve death. So it's your nerve's way of getting your attention to tell you to move your leg into a different spot. So you know that nerves need blood flow because you can do this little experiment on your own. And you can, remember when your foot has gone to sleep, and it's the most annoying feeling. Okay. Now later this semester, we're going to start talking about diseases that affect the peripheral vasculature, and there are unfortunately patients that have chronic diseases like type 2 diabetes or peripheral vascular disease, or in some cases both of those together, and they have that constant pinprick feeling in their feet and distal extremities. It's super annoying for them. Okay? All right, so astrocytes, a support architecture. This is the upper left. This is the picture of an astrocyte. You can see the blood vessel right here. And these are the oligodendrocytes up on the upper right. What about down here? What are these? Those are microglial cells. What do microglial cells do? They act like small macrophages of the central nervous system. So when you have a stroke in the central nervous system, you have damaged tissue. Instead of seeing a high prevalence of macrophages in that inflammatory response, you'll see what we call microglial cells. They have a phagocytic-like activity, but it's small capabilities of chewing up tissue, okay, or gobbling up or phagocytosing debris. The third or the fourth cell on the lower right are ependymal cells, and the ependymal cells are a glial type of cell that surrounds the choroid plexus, and it helps to facilitate filtration of the blood to produce cerebral spinal fluid. Remember that? And we're going to look at a couple of disorders that are associated with cerebral spinal fluid production or drainage, or both. Now out in the periphery we have satellite cells and Schwann cells, and the satellite cells perform a function that's very much like astrocytes. So they provide a nourishing type of role to the neuron. And the Schwann cells, they're cousin to who? The oligodendrocyte. The Schwann cell in the periphery is what's responsible for manufacturing the myelin. Okay, so very good. Now, if we continue on our review, again, this is all review, you remember that we further characterized the nerve at different locations. And what's really important to us is what's going on at the synapse. And so this is a drawing from a different textbook, from a Mosby textbook, but you can kind of appreciate the way this is drawn, that here is the nucleus, and here is our axon, and we have axoplasmic flow, and the axoplasm is the inside fluid that is synonymous with the cytoplasm in just a run-of-the-mill average Joe cell. But this cell is very specialized because of the way it's organized. And we've got the nucleus up top, and you have all sorts of typical organelles that you would expect to see in any cell. The only one that you don't really see in most neurons are centrioles. Why don't you see centrioles? Because nerves are typically, what? Unable to divide using mitosis. So you don't need centrioles if they're not going to go through mitotic division. But you see everything else. You see microtubules, you see the nucleus, you see endoplasmic reticulum, the Golgi, even cytoplasm, which we have a special word for, which is axoplasm. Then down here at the presynaptic terminal, we have these vesicles. And these vesicles are storing various types of compounds. Most commonly, they're going to be what? Neurotransmitters. They fuse with the membrane, they dump their content, the neurotransmitter binds to its appropriate receptor on the postsynaptic membrane, and you propagate the signal either to another nerve or to an effector organ like a muscle. Okay? So there are things that could go wrong anywhere along the line of this transmission of the signal. We also talked in 201 the big differences between the central nervous system and the peripheral nervous system. And just to remind ourselves, the CNS consists of the brain and the spinal cord, and the PNS is everything outside of that. Everything outside of that, the peripheral nervous system, also includes spinal nerves and cranial nerves. So the cranial nerves that come out of the brain, right, and they innervate in various locations like the vagus nerve or the facial nerve, the abducens, so on and so forth. There's 12 of them. Those are considered peripheral nerves. We also know that peripheral nerves have the capability of regeneration to a certain extent, and central nerves do not. And so in some patients that have sort of a facial nerve problem, there could be some slight regeneration that takes place because it's a peripheral nerve. But if a patient has a stroke in the brain, then those nerves will not regenerate. Now you can reroute to other areas using other neuronal pathways to send a similar signal to perform a similar function. And that's why PT is so valuable for post-stroke patients, because you can train the circuitry to use a different neuronal pathway. Okay? All right. Continuing on with the central nervous system, just a quick review. We have these different regions. And if you don't remember these different regions, I think it's a good time to look back at your 201 notes, or you can go into your resource folder for this class and you can look at the 201 notes that I use for my 201 class. Okay? You could even go onto YouTube and probably find the lectures. You can find the lectures there, and you could watch those lectures if you really need to. But I just want to highlight two big ones right now. And I want to present it to you in the following way, because depending on where and who you took 201 from, they may or may not have explained it to you this way. So the central nervous system is organized in a very specific fashion. It's organized from a posterior to an anterior perspective. And if you look at that motif all the way down the spinal cord, it's preserved. So for example, sensory information tends to come in the posterior aspect or the dorsal aspect. That's also true on the spinal cord. You have sensory afferent pathways coming in on the dorsal root. Okay? Then they go up to the brain, or the sensory information towards the posterior aspect, like let's take vision. And you see vision of a full classroom, and that moves forward, and it moves forward hitting different centers, speech centers, effector types of centers. You send an efferent pathway down, it comes out on the ventral root horn, or on the anterior aspect, and it goes to move the tongue and the mouth, and the vocal cords are activated, and we're lecturing in front of a full classroom. Okay, so everything is really sensory towards the back and motor towards the front. And so one of the best ways to remember this is the spinal cord. That's part of the central nervous system. But also to remember the difference. This is the posterior aspect of the brain. This is the anterior aspect of it. Here's the frontal lobe, right? And here is our occipital lobe. And if you look at the Wernicke area, and if you look at Broca's area, and if you remember back to 201, or if you didn't, we'll just talk about it now. We have these patients that fall in these categories of having stroke to certain areas of the brain. Right? And if you had a patient with a stroke towards the back that affected Wernicke's area, this is sensory. And so Meninges area is responsible for the sensory perception of speech. And so these individuals have trouble understanding speech, or even understanding what they said. A patient that has a compromised Broca's area, this is motor speech, so they might have a stutter, they might have the inability to form sentences post-stroke. Now there are certain types of infections that can affect these areas as well. Now in this lecture we only have one day, and typically we have 2 days, and that's why you've got 2 quizzes. We're trying to cram a lot in, but there are posted on YouTube 3 videos that I think you'll find fascinating. Okay? The first video is about a patient named Clive. And he was a very popularized musician. And he's from the UK. And he had a problem with a herpes virus that took over his central nervous system. And it caused damage to certain centers, including his hippocampus. And hippocampus is responsible for what? Memory. And so he has maybe a 2-minute memory, and that's it. His short-term memory is limited to 2-minute periods of time. Okay? So we've already been in here for what? 15, 20 minutes. So I would have said the same thing about 10 times to you, thinking it was fresh every time I said it. Okay? Now his long-term memory is fine. You'll see in this video, he knows his wife, Deborah, quite well, and because he's very passionate about her. Okay, and it's over-the-top passion that you see. I mean, nothing inappropriate, but it's over, like she walks in the room and he's like, "Oh, good to see you," right? And it's remarkable. I mean, he's very animated with it. But he had damage to the hippocampus. So if we know that these patients are having damage to certain lobes or certain centers, we can usually figure out what happened. Okay? Then there's a second video of a patient who had a severing of the corpus callosum. He was a patient that was suffering from a lot of seizures, and so they cut the corpus callosum, which is the main white tract that bridges the 2 hemispheres. And in so cutting it, they were trying to prevent the local seizures from becoming grand mal seizures. This is an old. These videos are pretty old, by the way. Some of them came off of a VCR tape. Some of you are like, "What is that?" Okay. It's irrelevant what it is, but it's not digital. Okay. But it's low quality, and we converted it to digital, so we could. You can't put VCR tapes on the internet. Okay, it just doesn't work. So you got to digitize it before you put it up there. But if you can kind of get past the quality and see the way this patient behaves, this person had trouble. The left hand would act independently of the right hand. Okay. Then there's a third video about Alzheimer's. Alzheimer's. And the Alzheimer patient, the 2 pair are twin brothers. And one brother developed Alzheimer's early, and the other brother did not. And we'll talk a little bit more about Alzheimer's, but these 3 videos that we're not going to have time to cover, I really want to encourage you to watch them on YouTube. Okay? But where the importance is when you watch these videos is remembering, here's the corpus callosum, right? The hippocampus, you can't really see in any of these slices. Okay? It's an internal structure. But if you remember back to 201 what the different centers were responsible for, and you have patients that have behavioral issues, if you trace back what the behavioral problem is, you can probably figure out without any imaging where the stroke or where the damage was, just based upon what's happening. Are they having trouble understanding the speech, or are they having trouble forming the speech? So a perfect example of this is going to be, do you remember the senator, Gabby Giffords from Tucson? Okay, so she survived this basic assassination attempt. And some disturbed individual came into a shopping center and started firing. And she got hit in the head a couple of times with bullets and survived. And if you look on the internet and watch interviews with her as she progressed with her PT, she becomes much more proficient with verbalizing and speaking. In the very beginning, she had such a large amount of damage to Broca's area on the front portion of the book. She knew exactly what she wanted to say. She just was having trouble forming speech patterns. And that's where speech therapy and physical therapy comes into play, which many of you are going to be doing in the future. And she has become, it's not back to normal. I mean, nothing will be back to normal after something like that. But she has improved significantly. And her husband was the astronaut, right? And they were in the news. If you've been living under a rock, you probably haven't heard of her. But you can just Google Gabby Giffords and watch some of the interviews with like Barbara Walters, early interviews after the injury when she first started coming out and talking, and more recent interviews. And it's unbelievable how much improvement she's been able to make. Okay, question?
Yeah, would it affect the ability to write? Would it, like, to communicate, if she had trouble speaking, she could write it out, or would it?
No, she could write just fine.
Okay.
Her motor function was totally fine.
Yeah.
So, for example, right, the sensory cortex is here, and the motor cortex was here, and so there wasn't really much damage to the motor cortex. There was a little, but it didn't affect her hand. It affected more of her lower extremities.
Oh,
so she did have some gait issues that she had to work through. But she could actually, and in the early phase of her recovery with her husband, she would communicate by writing things out instead of trying to speak. Okay? If it was Wernicke's, you wouldn't be able to really understand what people were saying very well, or you would have trouble picking the words. You could create the sentence just fine. You could form the sentence, but the sentence might sound purple or yellow, and you didn't mean to say green or blue, because what you were trying to learn was hearing. Does that make sense? So you can talk just fine, but it sounds very garbled. There's no stuttering. I chose the words perfectly. It's just the wrong words.
In that situation, if they wrote it out, it would probably still be the wrong words.
No, it probably would be fine if they wrote it out, because it's sending the information to the motor cortex to then actually write it out with the hand.
So it seems normal and thoughts that they can't say.
Yeah, and then they hear what they're saying, and they're like confused because they didn't mean to talk about colors at all. Okay? All right. All right, so let's continue on our review. If we look at the meninges and the ventricles, these are coverings. The meninges are the coverings in 201 that we talked about. We'll talk about meningitis today. There's three main layers, right? What's the outermost meningeal layer? The dura. And what's underneath the dura? What's that? Well, so the arachnoid, but subarachnoid would be there. And then what sits right on top of the brain? The pia. Okay. And in the subarachnoid space is where you flow what? Cerebral spinal fluid that's manufactured in the ventricles. And you have two lateral ventricles in the middle of the brain, right? Right and the left, called lateral. You have a third ventricle that they drain into, and then a fourth ventricle kind of in the brainstem, and then it flows down the central canal and back up through the subarachnoid space. And we'll talk about that flow pattern when it gets altered in some of the disorders, and I'll show you something that is actually a fairly recent occurrence. Because a lot of times in these classes, they show these old pictures from Google Pictures, and people are like, yeah, you know, that's like this, you know, it's kind of this funky head of this little kid. You're like, that doesn't really happen. It happens still. And I'll show you a case example of something that happened in India, in other, not in our country very often, because we have pretty good health care. But it still does happen. And then as we work our way down the central nervous system, there are different, higher order thought happens up top, right? So another way that the brain is organized, sensory towards the back, motor towards the front, but it's organized from a top down as well. And it's also organized right to left. So you need to remember this, because if I asked you on the exam, there was a stroke to the right cerebral hemisphere of a patient affecting the motor cortex, where would that manifest itself in that particular individual?
The opposite side.
The opposite side, because it decussates, it crosses over. And the right hemisphere on the motor side controls the left side of the body. Right? So if you had a patient that had a stroke and the left hand is kind of doing this, you know what I'm talking, this is very common, and it starts to atrophy a little bit on this side, and then their walk is a little awkward on the left, that usually means there was probably a stroke on the left cerebral motor cortex. So right to left organization, back to front, and then top down. So the top down that we're showing here is the higher order functions are usually very high up in the central nervous system. Like reasoning is in the frontal cortex. Your intellect, your personality is in the frontal cortex. Right? Who you are as a person. Whether you're funny, or whether you like to laugh, or whether you're quiet and reserved. These personality differences reside in our frontal cortex. That makes us who we are. That's extremely high-level thought. Versus just all of us being a robot and behaving exactly the same way. Okay? Like lower-level animals that have brains and central nervous systems. Okay? There's some personality in some of those, but if you move lower down, you'll see that they're more behaviorally all the same. Okay? So the top down, and the less complicated, still important, but the less complicated, like autonomic functions, like breathing, heart rate, right? All that stuff happens more in the brainstem as you move further down. Reflexes happen down at the level of the spinal cord. Or you touch something, you're like, ooh, and after you've moved it away, it registers later, that was hot, right? It's like you touch it, you move away, and then you realize it's hot. So reflexes are happening at a very low basic level. So let's talk about some of these centers. For example, like the pons. Not exactly high up on the brain. It's important. Don't mistake lower level processing with unimportant. Lower level processing doesn't necessarily mean it's not an important function. Higher level processing is things like complicated problem solving, studying for this class, okay? Interacting with multiple people, interacting with complicated people, people that you don't necessarily want to interact with, okay? Those are higher level functions that we use. So like the pons, for example, it's associated with sleep, hearing, equilibrium, eye movements, respiration, swallowing, bladder control, as well as posture. If we move towards a little bit more of the posterior, the cerebellum, all of this is review, by the way, guys. If it sounds like I'm going super fast, it's because you already had this as a prereq. I'm just trying to remind you, before we move into some of our pathology, what it is that we've already covered. The right and left hemispheres are connected by a vermis instead of a corpus callosum. And it also has these folds, just like what we see in the cerebrum. It primarily controls motor muscle control or muscle coordination. But it has a large density, like over 50% of the neurons that we have in the brain are located in the cerebellum. It's a very dense structure. But yet it's small. It's less than 10% of the total brain volume. Some of the other structural features, you remember the arbor vitae, which is, it literally translates in Latin as arbor meaning tree and vitae meaning life. So tree life, or the tree of life as we like to translate it. And so that's that branching pattern. You know, it looks kind of like cauliflower, in my opinion, when you slice it. That's why I hate cauliflower. Okay? I also hate broccoli, but I can't think of a reason I don't like broccoli other than it's just disgusting. I'm sorry, if you love broccoli, I really, truly apologize, but I told my wife, I was like, you know what, I don't have to eat it now, because I am an adult, and I don't need to do it now. She's like, well, what about the kids are watching? I take vitamins, that's what I tell them. Okay, I'll eat lots of other green stuff, but not broccoli. I love salad. Broccoli is gross. Okay. So, what was I talking about? Oh yeah, the arbor vitae, right? This sits right above the fourth ventricle. You can see here is our fourth ventricle that houses cerebral spinal fluid. And then it moves down from there into the central canal. So this is all review, but I'm trying to jumpstart your memory of what we covered. So if we look again back towards some of the brainstem functions like the medulla oblongata. Really an outgrowth of the spinal cord. A lot of autonomic control. We have cardiac centers here, and we also have centers for a lot of reflexes like sneezing, gagging, and swallowing, as well as coughing. The death by hanging. So the location of the medulla, the axis vertebrae in the neck, the cervical vertebrae, sits specifically right at the level of the medulla oblongata. And so in old methods of capital punishment, when the neck would be snapped by hanging, the goal was to have the axis come in and pierce the medulla oblongata quickly. And so it's considered a very humane way of death. Okay, plus you could sell tickets and lots of people from the township can watch. Kind of morbid, I know. But there was a lot of thought process into it. And that would snap in the neck at that location and piercing the medulla oblongata with the bony structure of the axis would actually stop respirations and the heart rate immediately. And that's why it was considered to be a very humane way of doing it. Okay? Even today in sniper fire, that's where they're targeting when they're trying to take out a target from a long distance away. If they want to drop the individual quickly, they'll try to shoot right through at the base of the skull and hit the medulla oblongata. All right, then we also looked at the organization of the autonomic nervous system in 201. And this organization can be summarized very quickly on one slide, I know, but as a sympathetic tree and a parasympathetic tree. And our sympathetic tree was responsible for things such as what? Sympathetic tree stimulates what types of activities? Okay, fight or flight, what does that mean? Like heart rate goes up or down? Up. Respirations, they go up. Basal metabolic rate goes up. It's getting the organism ready in an aroused state for fighting off an enemy or fleeing from a predator. And then the sympathetic or parasympathetic tree is just the opposite, right? So it's a rest and digest type of activity, where it slows down respirations, slows down heart rate. It basically gets you ready to go to sleep. Okay, so we're moving now away from our review, and we're going to get into some of the disorders. And the acute brain disorders, I want to remind you back to the ventricle system that we talked about, as well as the meningeal layers. We're going to look at some issues that talk and compare and contrast cerebral edema versus hydrocephalus. So hydrocephalus is something that you covered in 201. It's very common. And hydrocephalus is an increase in the production of cerebral spinal fluid. And usually, in parallel, you're going to have a decrease in the drainage of cerebral spinal fluid. Now, cerebral edema is on the bottom figure. So the top figure is hydrocephalus. Hydrocephalus in the top image. This is a coronal section, so it's cut like this. And you're looking from the front. And what is this structure and this structure in this particular brain? Lateral ventricles. So this is the right lateral ventricle, and this is the left lateral ventricle. In this image down here, do you see how small they are? Right? And you're like, that's why it looks, that's why I want to remind you what it's supposed to look like when we talk about it, so that when you see a picture where it's blown out like that, you can appreciate, wow, that is not normal, Keller. Okay? Nicely done. Not normal. This is also not normal. This is actually cerebral edema. But the lateral ventricles are about where they should be and about normal in size. That you see the midline, where this is shifted to the patient's right side, and the left side looks swollen. Do you see how this is lopsided? This is cerebral edema. So this is accumulation of fluid within the parenchymal tissue of the brain. What does the word parenchymal mean? I don't know, it's a word to say, it makes me sound super smart. Parenchymal tissue is functional tissue of that organ. So the functional, it's just another, it's a fancy $50 word to say the functional tissue of that organ. So an increasing fluid composition in the parenchymal tissue of the brain is causing this basically to swell with fluid, pushing the midline over to the patient's right, because this is the left lobe, this is the right lobe, and you can see the deviation from the midline, and this is cerebral edema down low, and this is hydrocephalus up top. Now with cerebral edema down low, that's what this slide is all about, because you should have already learned about hydrocephalus in 201. But in cerebral edema, what can cause that? Well, you can have two main causes, cytotoxic or vasogenic. Cytotoxic is usually an increase in the fluid in the functional tissue of the brain that's usually secondary to some sort of toxin or even endothelial injury and a hypoxic or an ischemic episode. And so you've got a toxin or you have injury to the brain that's causing fluid, edemic fluid, to move into the tissue. And that's usually what we see in an inflammatory response, right? Fluid edema in the tissue. Vasogenic has the word vaso, which is referring to the vasculature. So usually this is caused by a failure in the blood-brain barrier. And now you get too much fluid leaking into the extracellular matrix or the parenchymal tissue of the brain. And it can either be localized or it can be generalized all over the brain. So you might have localized swelling like this, or you could have swelling that's all over, either one. And it's usually caused by an inflammatory reaction towards the breakdown of the blood-brain barrier. Or in some cases, it's because there's a tumor. So vasogenic edema can be a result of a brain tumor in that particular location. So that tumor is growing out of control. It's bringing a lot of extra fluid into the surrounding tissue, and that causes a cerebral edema. And if it puts pressure on certain parts of the brain, it can actually shut down function. Right? Remember, the brain is confined by a skull cap. And so if you have a tumor anywhere else in the body other than the brain, it can actually grow to a very large size before it really maybe even is detected. But with a confined space of the skull cap, as it's growing, it's putting pressure up against certain other functional lobes in the brain, and that could turn off those activities. And that actually could be problematic. Yes, Siri, that's what it means. So, do you guys remember back to this question of what happens to ischemic or hypoxic cells? What happens to ischemic or hypoxic cells? What's that? They start decreasing the production of ATP, right? And it triggers all these different chain of events once ATP production goes down or is eliminated. And ultimately, it's going to lead to cellular death. Right? And if it leads to cellular death, now you're going to have an inflammatory response to clean up that debris. So I want to walk you through a case, but before we do that, let's take a picture of cerebral edema. So on this image, if I dim these lights, hopefully what you can appreciate is the skull cap has been removed in this post-mortem individual, and the brain itself, all of the gyri are flattened up. They have a flat edge as they've been sitting up against the skull cap. So these flat surfaces are not, they're usually supposed to be raised ridges. Here they're kind of flattened and spread out and almost smashed into the sulcus because of the increase in intracranial pressure. Now, cerebral edema is dramatically contrasted with hydrocephalus. And I found this case a couple of years back of this individual. This is now about 2 years old. That's it. So we're talking 2013. It's 15 right now, right? Yeah. So 2013. And this is a little East Indian girl named Runa Begum. And she was suffering at 18 months of age with hydrocephalus. So this is not cerebral edema. This is overproduction of CSF and an under ability or a decreased ability to drain the cerebral spinal fluid. So her head grew to a circumference of about 94 centimeters. This is about triple the size of a normal baby's head. And her parents were obviously very poor by our standards. Okay, in their culture, it wasn't. They're obviously, there's really only two main classes there. Those are the ones that have money and the ones that don't. So they're obviously in the ones that don't category. Her father's a bricklayer. He earns $3 a day. Okay, so like 15 bucks a week. That's not even enough to have a Starbucks every day. Okay. So for about a year and a half, 18 months, they took care of her. And in April of 2013, there was a group of Norwegian college students that were traveling around for a journalist course. And they ran into Runa and her family, and they were very, very moved and decided to set up a crowdfunding website. And so the goal was to raise $1,600 US equivalent to cover her shunt surgery. So the idea is the cerebral spinal fluid is not draining, so they put in these shunts that take the fluid from the subarachnoid space back to the venous circulation. It's a very successful, simple, straightforward surgery that is done in the United States very early in life, before they're 18 months of age, and their head never, really looks like this. So in 2 months, they raised twice that amount, and in a 6-month period of time, they had more than $60,000 US. So she had 5 cerebral shunting surgeries. They didn't do just one. They got her head down to 58 centimeters. The normal range is 38 to 48 in that age group of a child. And then she had her final surgery on Christmas Day of 2013. So this is her, and I'm going to dim these lights so you can see it. This is little Runa, and these are not altered pictures. These are like legit photographs. And her eyes are actually open, but they are the lids are coming closed because of the increase in the pressure of her head. And so this is her after a number of her surgeries, and this is her more recently. Okay, and of course she's going to have a little bit of scarring, but she looks beautiful. So if you are going to do anything within pediatric medicine outside the U.S., there is definitely a chance that you're going to run into hydrocephalus still. And the reason I show these pictures again is the classic image that you Google search shows this black and white photograph from like 300 years ago. And students are always like, I mean, really, does that still happen? I was like, yeah, it totally still happens. This was just 2 years ago. Because when they're younger like that, their fontanelles haven't yet closed. So as the fontanelles close, most of them close within the first 2 years of life. Some of them start closing as early as a couple of months. But some of them stay open, and so the fontanelles will allow for that head to expand. In you and I, it would kill us pretty quick because there's no place for expansion. Okay. All right, so that's one. Yeah. Okay. Yes. In the back.
How often do they do shunt replacements?
In the U.S.? I don't know. I don't know the number.
So after someone gets a shunt to try to get that shunt, they have to get another one and they keep updating it? Or?
No, usually in the U.S., when the shunts are done, it's one procedure when the baby's infant's very young, and it usually takes care of the problem. And in a lot of cases, as the infant grows, the shunt's not even necessary so they kind of grow out of the problem where the sinuses that are supposed to drain the cerebral spinal fluid actually develop to a greater extent, and it kind of corrects the issue. It's just that sort of early phase, like where Runa was, where it's super, super dicey. Something over here, yes?
Was she regaining her brain function?
Well, so that's kind of, I'm still trying to follow it, and I didn't see anything new about 3 months ago when I looked. I didn't look today. But there was a most recent report from her dad that was talking about, right about when this picture came out, and he was just saying how grateful he was, how excited he was that his little girl looked so beautiful. You know, and that's how it translated from their language. But I thought that was pretty neat. So I'm trying to keep track of it because it's a modern day example to bring into a classroom where a lot of times students think that a lot of the stuff that we learn about is not relevant to what we are going to be seeing. And there was another question over here.
It was just to answer her replacements. My sister has spinal bifida, so when she was young, they had to put in a shunt for her, and usually, like you said, they aren't replaced. But if you have a case like spinal bifida, you have to replace as they get older, just
Right.
because their body's developing as well. So they only had to put 4 in her because 2 of them had failed as she was growing up. But she has one now. It's like her responsibility.
Yeah.
She's managing diet and exercise.
There you go. So a little different case with spina bifida, actually a little bit more severe to treat, just because there's a lot more going on. I mean, believe it or not, with appropriate treatment with hydrocephalus, it's really not that complicated. You just have to have early intervention. That's the problem. You know, and in a lot of other countries, they don't have the kind of health care that we enjoy here. But yeah, many of these are treatable, including spina bifida. But again, slightly different, so it doesn't surprise me if they have to do multiple procedures in order to adjust the device therapy based upon how she was growing and how things were straightening out. Okay, so let's talk about another one, brain herniation. Brain herniation. This is due to an increase in intracranial pressure. So in these cases, untreated, you could have brain herniation of cerebral edema or with hydrocephalus. These herniations have specific locations that they tend to show up in, and so they're kind of labeled based upon those locations. The most common problem associated or cause of a brain herniation is an infarct. An infarct would be where blood flow is cut off to a certain region of the brain, and the patient has a stroke in that area or a damage to that part of the brain. And as the swelling takes place from the inflammatory episode, you get regions of the brain that herniate outside of where they're supposed to be located. So we've got different locations like uncinate herniation or a subfalcine herniation or a tonsillar herniation. Now, there's a sort of a special type that's found in the brainstem, and it is a type of brain herniation, but we refer to it as a hemorrhage, a Durrett hemorrhage, after the individual that characterized it. So the Durrett hemorrhage that shows up in the brainstem was named after Henry Durrett, who first characterized this type of brain herniation. So moving on from brain herniations to cerebral vascular disease. So cerebral vascular disease is just another name or another word for describing a stroke. And the abnormality is typically due to a blood vessel issue. And the blood vessel can have a couple of things that happen to it. Number one is you could have what we refer to as a thrombotic occlusion. So the vasculature that perfuses the brain itself comes up from the carotid vessels of the neck. It bifurcates into the internal and the external carotid. It comes up to the top of the circle of Willis, and then from there it branches out into smaller diameter capillaries that perfuse the rest of the brain. Anywhere within that vascular tree of the brain, you could have an occlusion due to a clot. That's a thrombotic occlusion. You could also have disease that takes place. We'll talk about vascular disease in the very end of the semester with our cardiovascular section. But when you have vascular disease where the narrowing of the vessel, because there's lesions that form on the inside lining of the blood vessel, and it slowly starts to close it down. You've heard physicians give reports back like, there was 90% stenosis, right? That means a 90% blockage of the lumen. And so only 10% is still open, allowing for blood flow to come through. Well, what happens is if there's a embolic lesion that is upstream that breaks off, and it flows and gets stuck in that area, that's what we call an embolic occlusion. Something broke off upstream, it moved downstream to a narrowed spot, and it lodged there, and it blocked it off, or it occluded it. Both of these are going to lead to localized ischemia. And localized ischemia to the brain tissue is not a good thing. It'll decrease ATP production, and then you start getting the death of the cells with APT production going down, and ATP production goes down because you have no more blood flow. And that's one of the main ways you make large amounts of ATP is using aerobic respiration. So if you have damage due to local ischemia, then you're going to have an inflammatory event within the brain tissue itself, and it might lead to cerebral edema, could lead to a hemorrhage. Okay, all of this is as a result of a stroke. Well, this last little one is the vessel itself in a disease state when it narrows like this, is you actually get damage within the lumen of the blood vessel. So if I, can you guys see this marker? Is that too light? You can see it? So if you're looking down the tube of the blood vessel, and if this is normally where the endothelium is, and then here's your lesion, that's right here, and you've opened up all of this, okay, this is all blood flow here, and this is where this lesion is, and you've narrowed it, say, 20%, narrowing. Well, the wall here is actually becoming weak. The wall's becoming weak because it's becoming hardened. That's atherosclerosis. And so if it's pressurized on the arterial side, then you could actually have a vessel rupture at where that lesion is because that's a weak point. And that's considered a hemorrhage. When the blood leaves the vasculature and hemorrhages out. And that hemorrhage can cause direct tissue damage as it sort of ruptures out into the tissue. It can also cause secondary ischemic injury because if the blood's leaking out of the vasculature, it's not perfusing downstream like it's supposed to. Okay? So, with this concept of stroke in cerebral vascular disease, this is where we're talking about local events in one location with one particular blood vessel. Well, we also have challenges that can happen neurovascularly that are widespread, or they're global, in other words. So global ischemia is damage to the entire brain. It's usually because the patient's in shock, hypovolemic shock. So trauma patients that lose large amounts of blood volume and their systolic pressure drops below 50 millimeters of mercury, right? And systolic levels should be typically what? Pretty close to 120, right? Systolic pressures. So you're talking about less than half of where they should be. There's not enough pressure systolically during contraction to bring blood to the brain itself and then move it around. And so now you have this hypovolemic shock, and depending upon the severity of it, you're going to get different types of clinical outcomes. So, for example, if it's mild, then the patient will likely completely recover. There might be some temporary confusion or transient, meaning short period of time. Or in the severe, you could have widespread neuronal death. You could actually have death of the individual, or they may lose large amounts of brain function. Global ischemia. So focal ischemia, like what we were talking about before global, this is most often vascular in incident. And there's an occlusion of an artery. And as that occlusion takes place, there becomes an infarction event. And you can see in this slice of the right brain, here is a focal cerebral ischemic episode due to an infarction. You can also see that the midline is shifted to the patient's left. And so we also have cerebral edema associated with this cerebral ischemia, right? Now, the brain itself is a circle of Willis. If you remember back to 202, when you studied the circle of Willis, the blood flow comes up and it comes around sort of in a crown. And then it branches off into the different small capillaries. Well, one of the reasons for that crown setup is so that you have a lot of redundancy in the system. So if you have a blockage in one area of the circle of Willis, you can still have sort of a back way to get blood flow to many regions of the brain. We don't have that in the heart. There isn't collateral backup flow in the heart, but there is in the brain. The occlusion itself, again, we already talked about this on the previous slide, either due to clotting, which is thrombosis, or an embolism where something breaks off and lodges downstream. All right, let's break here for a minute, and we'll come back and start talking about transient ischemic attacks, TIAs.